So good evening, everyone. Welcome to the GSTT ENT Virtual Grand Rounds. I'm pleased to have Professor Keat Jin Lee with us here today, who's going to be talking about pointers and pitfalls in middle ear surgery. Professor Lee has literally wrote the book on ENT and ENT essentials and is a professor at Yale University, and we're very pleased to have you with us.
Well, distinguished faculty, colleagues, and friends, and I hope you can hear me clearly and see the PowerPoints or the slides. If not, let Rohan know, and he'll be helping me with this technology here. In order to do good middle ear surgery, the task starts not in the operating room, but really before the operating room. So it is very essential that in the preoperative evaluation, that you select your patients carefully and appropriately. That is a must. And of course, accurate audiology is very important. That goes without saying. At the same time, as surgeons and doctors, we need the so-called bedside skills of our five senses and what you can do without technology. And audiology, audiometers has been around for decades, but it's still a technology. And with technology, you have calibration situation, electrical wiring, static situation, and you have the human error situation. So first, you have to have good audiologists to do the accurate audiology testing with SRT, discrimination, proper masking. And then you come on as a clinician to use your tuning forks to double check. And when you double check, you're not doubting your audiologist, you're just being a careful person to double check for your patient. And the tuning fork comes in 3 different frequencies. You have the 256 fork, which carries with it, unfortunately, the vibratory sense. And at 256, they also are akin to the ambient noise of the examining room, the hospital corridor, or whatever. And it gives you a negative Rene at about 15 decibel airborne gap. So for all the reasons that I've just mentioned before, it is not very useful because we, no matter how good a surgeon we are, if a patient has a 15 dB airborne gap conductive loss, I don't think we should be operating because the risks are too high and the gain is too little. The next tuning fork is the 512 tuning fork, 256, 512. The 512 is a very good tuning fork to use, and if you have time to only do one tuning fork test, 512 will be the only one. But if you have time or if you are a trainee, I think you should start getting used to the 256, 512, and the 1024. The 512 will give you a negative Rene with an airborne gap about 25, 30 dB airborne gap, which is a good clinical indicator to do middle ear surgery to improve hearing. And we'll get into the details later on. Not everybody with a 25 dB airborne gap should be operated on, okay? We're gonna be a conservative, good surgeon. And the 1024 fork will give you an airborne gap about 35 airborne gap or above. So you could potentially miss some proper surgical candidates. And while you use the tuning fork to test one ear, it is also important to mask the other ear. Just like in audiology, you always mask the contralateral ear. And here you use a barrier noise box. That's what we call it in the United States. That may be by a different name. And it is nothing more than the loud white noise to do the masking, like a loud alarm clock, if you would. So you properly mask the contralateral ear while you do your tuning fork test on the problem ear. Now, the other way to also evaluate preoperatively is to look at the tympanic membrane very carefully. And I found that in a chronic ear case or in somebody with past childhood history of Eustachian tube dysfunction, multiple PE tubes. It will be a little hard to look at just with an otoscope. So the operating microscope with binocular vision will give you a better feel of that tympanic membrane. And also I've found that if you use a microscope and you want to pneumomassage the tympanic membrane, the use of a single otoscope, at least that's what is called in North America, to give you a good seal. So the combination of the microscope and the single otoscope, you can really do a good pneumomassage to evaluate the mobility and integrity of the tympanic membrane. Next slide, please. So we have talked about the tuning forks. We've talked about the pneumomassage. Now, in the case of, let's say, preoperative stapedectomy, where the tympanic membrane is perfectly normal and pneumomassage move pretty well, now you want to check one more thing. Does the malleus move? Because about 1.5% of large series of stapedectomy patients done by the House Ear Institute, the famous House Ear Institute, has also malleus fixation. So if a patient has otosclerosis plus malleus fixation, and you did not recognize it, and you did not fix it, you could have done a perfect stapedectomy, and yet the patient would have a residual conductive hearing loss. And I have found that in adult patients, if you warn them carefully that it's not going to hurt at all or hurt very much, that if you use the belly part of a rosen needle, not the pointed part, you could gently palpate and be very gentle the mobility of the malleus under the microscope. If the patient has malleus fixation in stapedectomy, it doesn't mean you don't do the stapedectomy, but now you have to free the malleus head also. And now you're coming in with a different prosthesis. It's no more an incus to over window prosthesis. You'll be from a malleus to over window prosthesis, which in great hands, it does not completely close the air bone gap. So you have to inform the patient of that. And if you have never done a malleus to over window prosthesis, learn it first in the lab. It is a quite different technique. It's not as easy as doing a stapedectomy with an incus to over window prosthesis. Then the other consideration is age. Stapedectomy, as you all know, you're all very well trained already at the Guy's Hospital in University of London. It's pretty simple. And therefore, if a patient is in good health, he or she can tolerate the stapedectomy under local anesthesia, maybe with a little sedation, but you don't need general anesthesia. And you could do it under an hour or even less if you're very experienced. So there's no upper age of limitation to do stapedectomy. But be careful, be conservative. Hearing aids are getting better, by the way. Is there a lower age? If you read the literature, most literature pointed out that in juvenile otosclerosis, and you do the stapedectomy, you get a good result, but the refixation rate or subsequent hearing loss is common. So if you are conservative, like I am, maybe perhaps we should not be doing stapedectomy on somebody, let's say, arbitrarily 14, 16 years old, okay? Now, if you have a large otology practice, you may come across several patients who has otosclerosis and also Meniere's disease. It's not that common to have both, but if you have a large practice, you might. Then the dilemma is that, do you do the stapedectomy to help close the air bone gap? Again, being conservative, my thinking, and I'm not telling you what to do or not to do, I'm trying to draw it out for you to do your own evaluation, is that a patient with Meniere's disease has fluctuating hearing loss. And you and I know that the fluctuating hearing loss is sensorineural, has nothing to do with a conductive loss due to otosclerosis. But the patient doesn't know that. To him or her, if the hearing goes down, it's a surgeon's fault, okay? And the other aspect is that in meningitis, you have endolymphatic hydrops. The saccule may be up to the foot plate of the stapes. And therefore, when you do the stapedectomy, it is possible you rupture the saccule and cause dizziness and sensorineural hearing loss. So for those small number of patients that you have with otosclerosis and meningitis, my conservative advice is don't do the stapedectomy. Equip them with a good hearing aid. Next PowerPoint, please. Here is a histopathological site showing the fixation of the malleus head to the epitympanum area. Next. Here is a histopathological site showing the saccule distended all the way up to the foot plate, which on this PowerPoint or this slide is on the northeast corner, the foot plate. So as you can see, when you remove the foot plate, it is quite easy to rupture the saccule. Next. Here's another endolymphatic hydrops picture. Next. Every now and then, you will come across a patient with osteogenesis imperfecta, and they also have fixation of the foot plate. So therefore, doing a stapedectomy in these patients will also help close the airborne gap. To be careful, osteogenesis imperfecta patients have a blue sclera and also very brittle bone. So which means when we do the stapedectomy, and when you're curetting the posterior superior canal, be a little careful not to be overzealous and fracture the tympanic ring, which may cause other problems, including facial nerve situation. And also when you're crimping the stapes prosthesis onto the long process of the incus, be a little careful. You want to crimp it tightly, but don't fracture the long process of the incus. Stapedectomy, for those who have done it, is a very elegant, bloodless procedure. So don't complicate your life. So if you happen to see a patient with exostosis and otosclerosis, don't be tempted to do the two procedure, which is a canalplasty, take out the exostosis, and the stapedectomy at the same time. I will stage them by about 6 weeks. Do the exostosis, enlarge the canal, get it well epithelialized and healed, and 6 weeks later come back and do the very neat elective stapedectomy. Again, if you have a large practice of otology, you may come across patients who are blind and also happen to have otosclerosis. Again, my conservative advice is don't do a stapedectomy, because in any vestibular disturbance for a seeing patient, they can compensate. For a blind patient, it's harder. So I would caution against doing a stapedectomy in a blind patient. Now we're going to look at two audiometric curves. Next. This is a patient with an airborne gap. The air conduction is down in the 70. The bone conduction is a descending curve. And the discrimination is pretty good, 85%, because when you have a flat air conduction curve, the discrimination is pretty good. Now you're going to be a hero. You do the stapedectomy. And I'm not saying you shouldn't do it, but let's say you did it. And you did it successfully. You closed the airborne gap. So you have now decreased the SRT. You improve on the SRT. But because now you convert the air conduction curve from a flat to a descending, you now drop discrimination. So improve SRT, improving hearing, but you drop the discrimination. And it is between you and the patient, if this were bilateral, whether you should do one ear or not at all. But I would suggest you don't do both ears if both ears were identical audiometric curve. Again, conservative. Next. Now, this is another audiometric curve, which you see the discrimination is bad. 15% on one ear, 20% on the other ear. And here is where your tuning fork comes in very handy. And the reason you get poor discrimination is not necessarily the patient's problem. It could be the problem of the audiometer. Because when you push the audiometer to so loud, it has static and therefore is not very accurate. So assuming that the patient has an airborne gap and you can bring the threshold from 80s and 90s to 50s and 60s, you have really helped the patient. And you have now also improved the discrimination score. Now to settle whether it is an airborne gap or not, because the audiometer can't really help you here, is your tuning fork. So with the tuning fork, proper masking with a barrier noise box on the contralateral ear, if it is really strongly negative, I would then caution the patient carefully about the pros and cons of the surgery and go ahead and do one ear at least. And if that is very successful, 6 months later, you can do another ear. Next. Now we switch quickly, since we don't have too much time on Zoom, to chronic ear. I believe all of you who are listening was not even born, or maybe just in grammar school or high school, when this great debate happened. Do you take the canal wall down in patients with chronic ear and cholesteatoma, or do you leave the canal wall up and do the facial recess approach? And there's great debate between the East Coast of America and the West Coast. Howard House, James Sheehy has one opinion, which is they leave the canal wall up. In the East Coast, Professor Shuknik, very well famous at Harvard, take the canal wall down. And then of course, if you take the canal wall down, you end up with a mastoid cavity. I was in training at that time. I studied the series very carefully, and I came out with a debate is not necessarily needed. It's the cavity size and the external auditory canal diameter and the meatus opening, size of the meatus that matters. So therefore, the top diagram shows a large cavity, artist rendition, with a small meatus and a small canal. So if you were to take the canal down, which give you better exposure to remove squamous debris, granulation tissue, and cholesteatoma, but you widen the meatus, you do a canalplasty, okay, particularly anteriorly because the canal is down, and if and only if, there was a debate at that time, if and only if you don't have residual cholesteatoma or squamous debris buried somewhere, then you could use a musculoplasty flap, which I'll show you, and to reduce the cavity size. So therefore, there's a few if. One, make the canal larger, make the meatus larger, and if there's no buried or leftover or residual cholesteatoma or squamous debris, then you swing in a muscular flap of adipose fibrous tissue to obliterate or reduce, not completely obliterate, reduce the cavity size. Next. Now, when you are redoing chronic ear, you got to pay attention. And for the trainees, go to the lab, go to the temporal bone lab and learn all these areas as well as they are at the back of your hand, so to say. We're going to talk about the epitympanic space in a few more PowerPoints later in much more detail. You need to know where the zygomatic root cells are, because if you have an epitympanum cholesteatoma or squamous debris, some of it can invade into the zygomatic root cell, and if you don't clean them out, you would have residual or recurrent cholesteatoma. So you need to know where that is. And the way to look at it is to raise the table of the operating theater and turn or rotate the patients away from you to look deep into the zygomatic root cell. Then you need to look carefully at the sinodural angle. And in this instance, you need to lower the bed of the patient and roll or rotate the patient towards you. Then you have to be careful about paralabyrinthine cells because you got to get the squamous debris out, but you cannot be too aggressive, otherwise you'll be doing a labyrinthectomy with a dead ear. You need to know exactly where the facial recess is and the sinus tympani. Go to the lab to learn. You need to know where the mastoid tip cells, because that is pretty much the forgotten area, to make sure, again, there's no granulation tissue, squamous debris, or cholesteatoma hidden there. Look into the protympanum of the middle ear, and there the way to look at that carefully, almost into the eustachian tube, is to raise the table and rotate the patient away from you. And the hypotympanum and the mastoid tip area are in that inferior vicinity. Next. The facial nerve is our enemy and our friend. More our friend. You got to preserve it, take good care of it, baby it. And the way to find the landmarks of the facial nerve is the horizontal canal. It is right there in the horizontal canal. There's a second genu of the facial nerve, and then it goes medial of the epitympanum, which we're going to talk about in the next PowerPoint. Then you have the cochleariform process. The cochleariform process is the anterior aspect of the facial nerve vicinity before it goes into the first genu. And you need to know where the cochleariform process is. And if you're doing a multiple revision, a patient who has many previous mastoidectomy tympanoplasty, the cochleariform process may be removed already, it may not be there. But I've found that if you look at the protympanum, or not the protympanum, I apologize, the promontory, look at the promontory of your cochlear capsule in the middle ear, there's a little groove. And that groove goes from the cochleariform process area all the way to the round window niche. And that groove is where Jacobson's nerve is. So if you are lost, look for Jacobson's nerve. And for some reason, because of multiple revision, the Jacobson's nerve is not there, look for the groove. The groove is there. And by tracing the groove from the round window niche, superior anteriorly, you will come to the location of the cochleariform process, and then you work posteriorly, you will again find the area of the facial nerve. Now we go to study the epitympanum. Next PowerPoint. The epitympanum is like a box, and you need to memorize that box. All the 6 sides of the box, like the back of your hand. Superiorly is the middle fossa. Inferiorly is the middle ear. Anteriorly, as I mentioned earlier, is the zygomatic root cells. Posteriorly is the auditors, the hallway, so to say, to the antrum. Laterally is the malleus head and neck. And most importantly, medially is your facial nerve. Next. When you're doing a mastoidectomy, you have to go to the lab to practice. The problem postoperatively, after you're done a successful mastoid tympanoplasty of recurrent disease, as I mentioned before, canal wall up, canal wall down, is meatus stenosis, canal stenosis or narrowing, projecting buttresses of bone, and exposed mucosa in the mastoid cavity. Next. You do a meateroplasty, you do a canalplasty, and you create what Dr. Shuknik called the kernel flap. And we're going to show you how to do that. And then you take the fibrous adipose muscular tissue to obliterate or make the mastoid cavity smaller. And again, I'm going to emphasize, if there is no residual squamous debris or buried cholesteatoma. And a simple thing like packing is important to eliminate granulation tissue and recurrent problem. Next. Now we're going to go through some PowerPoint slides. I did not bring a video because on the Zoom, another complexity in technology. You want to make your post-auricular incision about ½ centimeter before the behind the posterior or behind the post-auricular crease. And the reason you do that is so that you have a good-looking auricle post-operatively and will not look like a plastered otoplasty ear. Okay, next. And after you have done that, you use a large round knife, or whatever knife that you call it in the UK, to make an incision from so-called 12 o'clock to 6 o'clock, about 3 to 4 millimeters away from the fibrous annulus. Next. This is what you're doing now. Next. Now this is the artist rendition where that 6 to 12 o'clock incision is made posteriorly, a few millimeters away from the fibrous annulus. Next. Now you make an incision from where you make this circular round knife incision and bring it out towards the concha and flare out superiorly, and the other incision inferiorly to have a very wide base, vascularized flap, like a forehead flap. Here is a concha flap. Next. Now you can see the incision, okay? Superior incision, inferior incision, and the scalpel blade showing. Next. Here is the artist rendition, and little arrow there tells us when you are pushing up, do not push hard because you could transect accidentally the whole auricle. Whereas if you do a seesaw technique like the arrow, and then with a little pressure laterally, you could cut it through the concha cartilage and the fibrous tissue at the same time. And then you use again in the US, we call it the Stevens scissors, a curved Stevens scissor, and to widen the base of this so-called kernel flap. Next. Here you are. You have that flap. Next. Then you remove a crescent of a concha cartilage in that area, and you put your finger of your left hand, if you're right-handed, make sure you don't transect the flap, and just remove the cartilage, leaving the fibrous tissue with the skin on the kernel flap. Next. And here with the Stevens scissors again, you carefully do not perforate the flap, remove the crescent of concha cartilage. Next. And here it is, you remove that concha cartilage, and now you have a wide meatus. Next. And that is your flap. And you use a blade, again, to carefully remove excess fibrous adipose tissues. Next. And most of us nowadays use fascia, temporalis fascia. So I take the temporalis fascia, again, make it very thin by removing, scraping off the fibrous tissues. Next. And then I take a little what we call crusher, and we put it in there and we make one click, Don't click it to death. Just one gentle click, and I leave it at the back table of the operating theater. And when I finish with my temporal bone, not temporal bone, my mastoidectomy, then I now retrieve this fascia. Next. And it looks almost like a tympanic membrane. And you want it so thin and yet intact that you can read through it like the word or the alphabet E. Next. Now the packing. After you've done all that work, some people pack with this gauze, that gauze, whatever, which is fine. If it works in your hands, don't change. I'm not the know-it-all person. I'm just sharing you with my ideas. And I've found in every lecture I give, I learn something from the audience. And sometimes, every now and then, what I learn is not the professor from the professor, from a first-year resident. Of course, the professors, I learn much more. So you take what we call in the United States, TELFA, T-E-L-F-A, is non-sticking, and you make it like a cigarette butt, roll it up, and that size. I only put the scalpel to let you know the approximate size. It's like a cigarette butt. Next. And I put that in carefully against the corner flap. By that time, all the bleeding has stopped. You have to put your musculoplasty. This is the last step. The sutures are post-auricular sutures are placed in. You put it in carefully. Next. That's it. So there's no much packing to take out. And when you take it out, it's bloodless and painless. And we leave that in for good week or so. Next. Complications in middle ear surgery, as you all know already, is the facial nerve. Avoid it, know where it is. It's your best friend, not your enemy. Now, what I usually do, in fact, always do, as soon as the patient awakes from anesthesia, I'm right there, okay? And if for some reason of emergency, I have to leave the operating room, I make the resident promise me that he'll stay there. And as soon as the patient wakes up from anesthesia, we very quickly, in 10 seconds, check the facial nerve. Wrinkle your nose, squeeze on your eyelid, pucker your lips, something to make the facial nerve work. And immediately I document in the patient's medical records the time of that simple check, take 10 seconds. You can't say you have no time to do it, 10 seconds, and record now facial nerve normal. And the reason you do that is the following. If the facial nerve become paralyzed an hour later, 2 hours later, at night, the next morning, you know that you did not cut or severely traumatize the facial nerve because it worked after surgery. And therefore, to go back and to decompress the facial nerve may be an unnecessary surgery. On the flip side, if as soon as a patient awakes from anesthesia and you check and the facial nerve doesn't move, that means you cut it or you severely damage it, which under American law doesn't, it is not malpractice to injure the facial nerve, okay? It depends on the case. But you'll be bad form if you detect an immediate facial nerve paralysis and you don't go back and explore it and try to fix it. So if you have an immediate facial nerve paralysis, whether in a traumatic case or in this case, you should decompress it. Exposed dura. It's not uncommon when you have extensive cholesteatoma in the epitympanic space, you expose the dura. No big deal, okay? If it bleeds, you need to stop it. And don't try to cauterize. And if you have to cauterize, use very gently the bipolar, not the unipolar, because otherwise you can make the exposed dura worse by creating a CSF leak. And if it's a little bleeding, you get some gel foam or whatever you have in UK with a little epinephrine 1 to 1,000, not by injection, but by topical, it usually stops. So an exposed dura is not a big deal. Continue your mastoidectomy, your tympanoplasty, and check it afterwards. And if there's no CSF leak, there's no bleeding, go around your business, don't worry about it. On the other hand, if you have CSF leak, then you're going to be really worried. So therefore, if it's CSF leak, if it's a huge leak, then you better call your neurosurgeon friend. But I don't think you're that clumsy to make a huge leak. Then you pack it with gel foam, tightly stop it, and go about your work. And when you finish your mastoidectomy, tympanoplasty, 9 times out of 10, it'll stop. And if not, then you need to put a fascia there and pack it tightly. Now, once I discovered or noticed a CSF leak, no matter how minor, you have violated the CSF space, I always ask the anesthesiologist to give them a bolus of the appropriate antibiotic and keep the patient on antibiotic either intravenously if they are still in the hospital or orally, PO, we call it, at home. If you accidentally do a fistula, some cholesteatoma made the fistula for you, and that matrix of the cholesteatoma is covering up a fistula. And if you take away that matrix of the cholesteatoma, the fistula becomes more obvious. And I have found that if you're gentle with it, put a gel foam, and make sure you don't have any ototoxic drugs like corticosporin or anything in the operating site, because those are ototoxic. You remove all those so-called possible ototoxic drops and cover it up and seal it with the fascia. It usually takes care of itself. Okay, just be very careful. What is Bondi versus Max? The old term, which again, most of you are too young, you may not remember, what they call Bondi modified mastoidectomy. They believe that the cholesteatoma matrix is harmless. You exteriorize the cholesteatoma, like a sebaceous cyst, and you leave the matrix to keep the fistula sealed. Max stands for Max Abrahamson. The late Dr. Abrahamson and I were resident together. He was a very famous professor at Columbia University. And at a very young age, in his 40s, he was in a bicycle race in one of the ENT meetings, and unfortunately, he hit a truck, or a truck hit him, and he passed away. But if you believe in my old resident mate, Max Abrahamson, he believed that the matrix of the cholesteatoma secretes an enzyme that continues to erode bone. And therefore, his belief is you always remove the matrix. Now, whether you're a Bondi guy or Max, I leave it up to you. I believe in the Max type, so I remove the matrix and carefully patch that fistula with a fascia. The sigmoid sinus, it can scare you half to death because any little nick on the sigmoid sinus give you a gusher of this venous blood. It can be very scary, but don't be scared. And the reason is when we do glomus jugulare tumor, we have to get into the sigmoid sinus, open it up to get the tumor out. And the bleeding always stops with packing. You're not going to get so much bleeding like in removal of glomus jugulare tumor. You get some bleeding, it can scare you. Don't be scared. Pack it very carefully with Surgicel, which is self-absorbable, and then pack it on top with gel foam or whatever, and go around your business doing your mastoid tympanoplasty. When you finish, come back and check it. I would say 99 out of 100 times. Hopefully you don't have that many, maybe 9 out of 10 times or whatever. The bleeding will stop. And if it's not reinforced packing, it will stop. Don't worry. Next. This is what we call meningostepidopaxy. a type 3 tympanoplasty, where the tympanic membrane drape over the lenticular process of the incus and the head of the stapes. If there's good aeration of the middle ear, and there is a good, what we call phase difference, P-H-A-S-E, phase difference between the round window and the oval window, this patient can have a normal hearing, practically, maybe 10, 15 dB gap. So don't be a hero, try to reconstruct his ear. They're good hearing, leave them alone. Next. That is the histopathological slide, obviously not the same patient, one is alive, the one before, and this patient is dead with his temple bone, showing you the meningostapedopaxy, type 3 tympanoplasty. And the white space in the middle ear shows well aeration. Next. This is a coronary ear. The patient has so much fibrosis. And if the patient has poor SGLT2 function, has so much fibrosis, no matter what middle ear reconstruction, gymnastics, prosthesis, or whatever you do, okay, it's not going to work, not because of your technique, but because of the fibrosis always come back. Next. You have done your mastoidectomy tympanoplasty many times. You have great success. Every now and then you come across a patient who have multiple revisions before for some reason, and they still have problems. And the previous surgeons have pretty much used up all the fascia. And it is very frustrating. Dr. Van Hulset, a South African otologist who immigrated to Hong Kong, became the chief of ENT at Chinese University in Hong Kong, came out with what he calls the Hong Kong flat. I call it the Van Hulset flat to honor him, in which he made this large incision. Next. Almost like a craniotomy incision. So here you see the Van Hulset flap, and you see the Kerner flap. Next. And after he has finished the surgery, the mastoid tympanoplasty, he swing the fascia. He created a large piece of fascia. Next. To build the tympanic membrane and also to line the mastoid cavity. This is a canal wall down, obviously. Next. And this is what the patient looked like 3 weeks later. And this has helped me bring a dry, safe ear to many patients who had many previous mastoidectomy. And thanks to Dr. Van Hulset. With the COVID, we haven't kept in touch. I don't know whether he's still in Hong Kong or the United Kingdom or went back to South Africa. Thank you, Dr. Van Hulset, for teaching me this. Next. And this is what it looks like 6 months later. Next. A resident took the consecutive, and whenever you do a case study, make sure they're consecutive. You can't pick and choose your good results. A consecutive 500 cases of mastoid tympanoplasty. 88 of them have type 1 tympanoplasty, 340 type 3, 72 type 4, and you can see the success rate, the graft failure, and recurrent suppuration. Pretty successful. Next. Out of the 500 cases, consecutive cases, 227 cases have cholesteatoma, okay, preoperatively, the rest just chronic ear, and the recurrence rate of cholesteatoma is pretty low, 5.7%, 94% success rate. Next. And now we talk about the hearing. If you take the type 1, and there's a breakdown of the N, and if you give the criteria, the success rate is not bad. Next. Now you want to find out whether we cause any sensory neural hearing loss, or what we call loss of bone conduction thresholds. And there are some, and the statistic there speak for itself. Next. Now, occasionally you see a patient with very localized cholesteatoma in the epitympanum. Remember, we talk about that box, that epitympanum? And if the rest of the mastoid is clean, you don't need to do the mastoid tympanoplasty. You could take a rectangular type of a bone out, don't drill it down, cut it out, okay, saw it out, and get the cholesteatoma out and put this blown plate back. Heal up very fast. But it has to be a very well circumscribed, localized cholesteatoma in the epitympanum. Next. Now, this patient has an anterior canal bulge. Another problem in tympanoplasty is what we call delayed conductive hearing loss. And the reason it's delayed is the tympanic graft, which is symbolized by the dark color, migrate laterally. And therefore it loses contact with the malleus or with the incus or whatever. And in order to avoid the lateral displacement of the tympanic graft, anteriorly particularly, is to make sure you inspect the anterior canal wall to make sure there's no anterior canal wall bulge. And if there is, raise the flap, cutaneous flap, anteriorly, drill down the bone, and then put the flap back. And then when you put the tympanic graft, make sure it's right 90 degrees against the anterior canal wall, and you pack it tightly for 10 days and let it heal. Then you would avoid lateral migration of the graft 3 months or so later, causing a delayed conductive hearing loss. Next. As we mentioned before, you can do a lot of middle ear reconstruction, ossicular-plasty, but if you have poor eustachian tube function, it won't work. If you have a good eustachian tube function, using the body of the incus to interpose between the stapes head and your malleus handle can work very well. And I'm sure you have imaginations for other reconstruction. Next. Patient who comes in with recurrent otitis media and with effusion. They don't have cholesteatoma, but they got this problem. What do? We can put a PE tube there, and there is a good GODE past chairman at Stanford, famous university in America, good long-term tube. And we have found it does very well, but also it itself creates granulation tissue. So sometimes it's easier you customize yourself with a regular polyethylene tube and create your own PE tube for this patient. And there's another short lecture I give about how to make a PE tube very easy. Well, we don't have time for that today. And of course, if it's children, you want to make sure that aneurysectomy has been done, allergy has been treated, and in every occasion, you want to make sure they don't have HIV and don't have cystic fibrosis and don't have histiocytosis X, because all these patients will give you a child or a young teenager with recurrent otitis media with effusion and hearing loss, but no cholesteatoma yet. And there are many ways to make the diagnosis of histiocytosis X quite complicated, but a very simple one lateral view of your mastoid, plain film, not a CAT scan, of the mastoid will make a diagnosis of histiocytosis X. Patients with histiocytosis X on the plain lateral view of a Law's view, we call it, of the mastoid will show you punch-out lesion. You can pick it up just like that. Thank you. Next. This is my last PowerPoint. When resident or registrar, you call them, go to the temporal bone and dissect the temporal bone, they get up to the tip of the mastoid, the beginning of the stylomastoid foramen, and they stop because it's a temporal bone. There's no neck to it. Okay? And then the next month, they rotate through head and neck surgery. They now have a full head cadaver with soft tissue. And now they do this neck dissection and the paediatric. And they go from inferior superiorly, and they stop at the pes where the facial nerve comes out, and they stop. But don't stop. You have the temporal bone right there. Open up, join the neck dissection into mastoidectomy. Then you can see the real display of how the facial nerve leaves the temporal bone, come out near the infratemporal pitch temporal suture line, and into the neck and into the face. Learn that one. Okay? Yeah. That's the end of my lecture.
Do you use bone dust to reduce the size of the cavity?
I use the post-auricular fibrous muscular tissue. So is a carry with it is blood supply. That's what I use. But so some other surgeons use some adipose tissue of muscle taken, somewhere else. But I like the vascularization of the fibrous muscular tissue in the post-auricular area. And you don't need much.
Another question says, if cholesteatoma extends to the Otitis, but the rest of the air cells are filled with cholesterol granuloma, does that need to be removed, or is it okay to just leave that there?
Well, the goal of any mastoidectomy, in my mind, and in minds of many otologists, is to remove all, not just cholesteatoma, but squamous debris, because otherwise they will cause a recurrence. And I think if you are very familiar with the temporal bone, like I mentioned, all the crevices, the epitympanum, the protympanum, sinodural angles, zygomatic root cells, so on and so forth that are highlighted, you should meticulously and spend time and remove all of them without problem. Yeah. I think you can. I've never seen one where, now, the only time I've not seen it, but I can envision, if the squamous debris, not so much cholesteatoma. Cholesteatoma is an organized cyst. If the squamous debris is into the perilabyrinthine cell, then if you remove it, you may do a labyrinthectomy inadvertently. Yeah, but I've not encountered that personally.
Another question mentions, other than the Hong Kong flap, do you have any other methods that you use for obliteration?
No, I don't. It's just a post-auricular muscle, and the Hong Kong flap is an extensive way of doing it. Correct.
And do you use speech discrimination tests for all patients suspected with otosclerosis preoperatively?
I did not hear that question, please.
Do you use speech discrimination testing for all patients suspected with otosclerosis preoperatively?
Yes. Yeah, all my patients preoperatively, we do a full airborne testing, SRT, and discrimination. Correct. Yeah.
One of the other participants would like to know, how would you go about managing postoperative traumatic versus delayed facial nerve palsy?
Okay. Ideally, you are the person or some knowledgeable person happen to see the patient at the time of the trauma. And that is practically impossible unless you happen to be in the ambulance or happen to be right there. So therefore, it will be important to record as soon as you or teach your interns and teach your medical students that if you call in to see a patient with head trauma, it takes you, the patient has been very sick because they have a head trauma, to be very quickly check the facial nerve. It takes you really, Rohan, can you show me your teeth? Show me your teeth. It takes you what, 3 seconds? So as soon as the patient is awake, you do that and you document that. And now you say the patient facial nerve works. Then is a delayed facial paralysis. So my criteria is to treat facial paralysis immediate or delayed. If it's immediate, assuming that the facial nerve was cut, then as soon as the patient is neurologically stable, I would then do a facial nerve decompression or explore. On the other hand, it would delay. If you saw the patient and then move the facial nerve and half an hour later, an hour later, the next day, then it's delayed. And if it's delayed and if there's no contraindication, then we put them on steroids, almost like treating them as like a Bell's palsy. And then we follow those patients with certain facial nerve testing. Okay, either the Hilger, Hilger minimum testing, and there are many more sophisticated tests within the ENOC, so on and so forth, EMG. And if you suspect the exostemesis, that the neurons are going to quote unquote die, then I would go ahead and preempt it and do a facial nerve decompression. Otherwise, like in Bell's palsy, most of them come back. So the key point in treating traumatic facial nerve is whether it's immediate or delayed.
Thank you. One of our other participants has a question. Do you prefer primary or delayed vesicular reconstruction following a mastoidectomy? For cholesteatoma, I'm assuming.
Okay. In my practice of about 50 years, I have always done primary, in which I make sure the cholesteatoma is out, squamous debris is out, so on and so forth, and get good eustachian tube function, determine the best I can, and I will do the reconstruction right then and there. And if it fails, and there are some of them who will fail, okay, then I would then come and do a revision 6 months later. Now, I know where the question might start from. In the house group, in the 80s and before, one of the famous surgeons there advocated that you do the mastoidectomy tympanoplasty, and then you come back subsequently to do the reconstruction. And I'm not saying he's wrong, he most probably is right, but I'm saying that why not do it, and if it succeeds, you don't have to come back. If it fails, you're gonna come back anyway. Again, I'm not telling whoever is listening what to do. I like to discuss and let every surgeon decide for himself. As they say, you try to teach people how to fish than to give them fish. So I'm discussing it and let all the smart listeners figure out for themselves.
The next question is very specific, but in the case of recurrent infection on a cochlear implant, which was done 8 years ago with shrapnel perforation and temporarily improved in medical treatment in a patient that's 12 years old, what would you advise in terms of, I'm assuming, further treatment? Would you consider explant, reimplant, or?
Now, what is a patient? Is a patient now without infection or still have infection?
It says about recurrent infection with the implant, as well as shrapnel perforation.
I see. So I'm going to be specific. So recurrent implies to me that this 12-year-old has infection of that site every now and then. Is that correct? Yeah. Okay. If the infection is completely treated and never come back, I will leave them alone. But if the patient is, and I'm not talking about hearing, I'm just talking about infection. But if the patient continues to have recurrent infection, that means there's still a quote unquote foreign body effect, right? You remember in your other training that if you have a fishbone somewhere, if there's foreign or splinter, until you remove the foreign body, the infection is going to keep coming back. In that case, I would go ahead and remove the foreign body. But the other side of the coin is how's the patient's hearing. If the patient's hearing is very good with a cochlear implant, in spite of the infection and whatever happens, then you may not want to jeopardize that, because changing a cochlear implant may make a person who hears well with an implant into not hearing at all. So it's the last question, very specific question, but it's multifaceted. Correct, yeah. But the most important is infection, because it can lead to meningitis, brain abscess, so on and so forth. Yeah, but the equally or secondary important is the hearing.
There are still a couple of questions if you're happy, but it's completely up to you. We are well over time. Would you be happy to take a couple of extra questions, Professor?
Yeah, why not? Yeah, okay. And if I don't know, you answer them for me.
Perfect. Well, one question: what is your preferred technique for ossiculoplasty?
I try to use the patient's bone as much as possible, and which means you could use some of the, like the head, the body of the incus, so on and so forth, or you could carve a small, like doing sculpturing, bone from the mastoid. There's plenty of bone in there. To make an ossicle doesn't take much bone. I have tried ossicles that you can purchase, okay? I didn't find them quite as well. I have also limited success in the artificial ossicles, whether they're titanium and so on and so forth. And I have to admit that came later in my career, and maybe I'm not as familiar with them, right? Times change and you have to move with the times. So I don't want to talk about poor success with artificial ossicles, okay? Like titanium or whatever. So I respect those younger surgeons who have used them and succeeded. But personally, I like the patient's own tissue, which in this case is own bone, whether ossicles, part of the ossicle, or from the mastoid cavity.
Thank you. Just going back to, we talked about the delayed and immediate facial nerve palsy. A supplement to that question was, if the patient was comatose or intubated, how would your response differ, or your approach differ? I mean, I think am I right in saying that you would do the ENOG testing and the EMG testing, or?
Yeah. If you cannot design, I was not very clear, but maybe you could go and look up the literature. The late Dr. Sasaki, S-A-S-A-K-I, he was the chief of otolaryngology for 40 years at Yale. He's a head and neck surgeon, but he's in early days. He wrote a short article that in an unconscious patient, he is a way to squeeze the trapezius muscle and they will grimace or something like that. But I could admit, I haven't read that article recently. So maybe if you find that article, you could post it for everybody. So what he was saying is that if a patient is unconscious and you cannot check the facial nerve, by this Sasaki technique, you could get an idea whether facial nerve moves or not, okay? Yeah.
If you suspect eustachian tube dysfunction and have done a canal wall down mastoidectomy, do you, I'm assuming this is unblock the eustachian tube opening. Would you do that? Is that something that?
Okay, well, by looking into the protympanum, you remember earlier in my anatomical aspect of the lecture, that you could see whether eustachian tube is blocked by any granulation tissue or cholesteatoma or whatever, yeah. But sometimes the eustachian obstruction is not anatomical, it's physiological. Then I would bow again to the newer technique nowadays, which was not in existence when I was in training, the eustachian tube dilation and eustachian tube plasty and so on and so forth. Yeah, But you're right. If the eustachian tube is not functioning, no matter what middle ear reconstruction you do, it's not going to work. It's going to have effusion or fibrosis. Correct. So eustachian tube, next to facial nerve, the eustachian tube is our next important structure in the middle ear.
And do you select any specific patients for balloon eustachian tube dilatation? Do you have like a selection criteria? Is it based on symptoms? Is it based on tympanometry?
I think it's a combination of symptoms, longevity, recurrence of the symptom, and tympanometry. And it's not one size fit all test, so to say. Yeah. And also, eustachian tube dilatation is still evolving. It's still evolving. Yeah. It's not as set as mastoidectomy to clean out cholesteatoma. That I think has stopped evolving, maybe with a little minor changes, but eustachian tube situation is still evolving, and keep learning.
The last question, I'm sure it's a simple one. In terms of the packing material that you use for the external auditory canal, is it absorbable material? Is it antibiotic impregnated? You said it was telfar, right?
Okay. No, okay. Thank you for bringing it up. Before I put the telfar roll, ROLL, I squeeze in cortisporin ointment, if the patient is not allergic, into the external auditory canal where the kernel flap is packing. You're right. And then I put the telfar. The telfar itself is very smooth, so it's not absorbent. So if you put telfar, if you put the ointment on the telfar, you just slide off. And the reason I use a telfar is because it's smooth, and therefore it doesn't create granulation tissue. So I put the ointment inside first, and then put the telfar on top of the lateral to the ointment.
Thank you.
Very good. You people ask very good question. You're really listening.
It was.
I thought in Zoom everybody turns it on and go and eat ice cream or something.
Well, obviously you kept the audience very engaged. Thank you very much.